In an older adult carrying chronic pain, a long medication list is not several separate problems. It is one list, one person, and one fall. Reviewing that list with a view to reducing it has a name: Deprescribing. And it is a formal clinical discipline with published tools, not an admission that something was prescribed in error. Before anything else, one thing has to be said plainly. Do not stop, reduce, or change any prescribed medication on your own after watching this. Some medications must be tapered under supervision. An abrupt withdrawal of certain drugs, blood pressure medications among them, can cause rebound effects that are more dangerous than continuing. What follows is meant to inform a conversation with your prescriber, not to replace one. Deprescribing is a discipline, not a lapse. Stop, start is a physiological, systems-based, explicit set of criteria that defines clinically important prescribing problems. The stop criteria cover potentially inappropriate medications. The start criteria cover potential prescribing omissions. It matters that both directions are covered. The framework is as concerned with what is missing from a list as with what should come off it. The current version is version 3, published in 2023, following earlier versions in 2008 and 2015. It was produced from a system-by-system review of literature published between April 2014 and March 2022, then validated over 4 rounds of Delphi consensus by a panel of 11 academic physicians. With recognized expertise in geriatric pharmacotherapy from 8 European countries. If you look this up yourself, check which version you are reading. Summaries circulating online frequently describe superseded editions. Now, the sequence worth understanding, and it is specific. A blood pressure dose that is tighter than the person needs can produce orthostatic hypotension, which is a drop in blood pressure on standing. That causes dizziness, or faintness on rising. That causes falls. And falls cause fractures and head injuries. The resulting harm has nothing to do with blood pressure. It arrives entirely through the fall. This is why a medication list in an older adult is reviewed as a whole rather than one prescription at a time, and why fall history belongs in a medication review. Next, the statin trade-off. Stated plainly, statins are associated with a modest increase in new onset type 2 diabetes. And it is better to know that than to encounter it as a surprise. A collaborative meta-analysis of 13 randomized statin trials covering 91,140 participants. Found statin therapy associated with a 9% increased risk of incident diabetes, with little heterogeneity between trials. Over a mean of 4 years, 4,278 participants developed diabetes. The risk was highest in trials with older participants. In absolute terms, treating 255 patients with a statin for 4 years resulted in 1 extra case of diabetes. The author's own conclusion is the part that must travel with the figure. They concluded that the risk is low both in absolute terms and compared with the reduction in coronary events. And that clinical practice in patients with moderate or high cardiovascular risk or existing cardiovascular disease should not change. So this is a trade-off to discuss. Never a reason to stop a statin on your own. Both halves of that sentence are load-bearing. Where does a pain practice fit in any of this? Older adults living with chronic pain tend to accumulate the longest medication lists because each symptom attracts its own prescription over time. The contribution an interventional pain practice can make is narrow and specific. Treat the pain at its source, using image-guided procedures aimed at a confirmed generator so that the medication burden has room to come down under the prescriber's supervision. That is the whole of it. Your blood pressure and cardiac medications remain the business of the physician who prescribes them. What can change is how much analgesia the pain itself demands. At the Padda Institute, that work runs through the range of pain treatments and through opioid stewardship, and for the behavioral component, counseling for chronic pain, which is delivered in-house. Where cognition is a concern in the same conversation, cognitive assessment is available. a few questions come up every time. Is deprescribing an admission that your medications were wrong? No, it is a recognized clinical discipline with published validated criteria covering both medications that may no longer be appropriate and treatments that may be missing. A medication that suited you at 60 may not suit you at 80 without anything having been done incorrectly. Should you stop a medication if you read that it causes falls? No. Bring that question to your prescriber. And what should you bring to a medication review? The full list, including doses, and anything bought without a prescription, plus a record of any falls, any dizziness on standing, and any near falls. That history changes how the list is read. To discuss pain treatment that may reduce what your medication list has to carry, request an appointment at painmd.tv/appointment. Call 314-481-5000 or text 314-886-5902. We have 2 locations, 4477 Woodson Road, Suite 100 in Street Lewis, and 12174 Natural Bridge Road in Bridgeton. You do not need a referral, and you do not need to be an existing patient. Medication changes remain a decision for your prescribing physician. Padda Institute, Center for Interventional Pain Management. Fixing the terrain, signal by signal, medication changes remain a clinical decision.